There is a number that almost no one talks about in the preoperative consultation, and it is the number that arguably matters more than any other statistic on your surgical consent form. 30 to 40%. That is the proportion of patients over 70 who experience measurable cognitive changes after surgery under general anesthesia. Not 1 or 2 in 100, 3 to 4 in every 10. And the part that stops me every time I share this with a patient's family is that most of those families had no idea this risk existed before the operation. Nobody told them, because nobody asked the right question before their loved one was wheeled into that operating room. If you are over 65, or if you are preparing for surgery in the coming weeks or months, or if someone you love is facing a procedure and you want to walk into that consultation genuinely informed. This video is the conversation your surgical team may never start on your behalf. By the time we are done, you will understand exactly why general anesthesia carries elevated risk for the aging brain specifically, what 4 alternatives exist and when each one applies, and the precise language to use with your medical team before the operation begins. Stay with me. This matters more than most people realize. Let me start with the question most families never think to ask. When a surgical procedure is scheduled, the natural focus lands in one place: the surgeon, the technique, the success rate of the specific procedure. Is this doctor experienced? What is the recovery timeline? Will the pain be manageable? These are all completely reasonable concerns, and I am not dismissing a single one of them. But here is what I have observed across decades of clinical practice. For a patient over 70, the surgery itself is frequently not the greatest risk. The type of anesthesia is, specifically general anesthesia, the kind that does not simply sedate you, the kind that chemically suppresses the brain to a deep level, places a tube down the airway, and hands the work of breathing entirely to a machine. For a healthy 40-year-old, the brain absorbs that pharmacological event and recovers efficiently. For someone over 70, that same suppression lands on a brain that operates with measurably less cognitive reserve, and the recovery is a different story entirely. Understanding why requires understanding one specific concept: cognitive reserve. Cognitive reserve is not about intelligence. It is not about decline or weakness. It is the brain's physiological buffer, its capacity to absorb a significant chemical disruption and return to baseline cleanly and completely afterward. Younger brains carry substantial reserve. The margin for error is wide. Older brains carry less, not because of anything the individual has done or failed to do, but because of the natural biological changes that accumulate across 7 or 8 decades of a human life. Cerebrovascular microcirculation changes, receptor sensitivity shifts, drug metabolism slows as kidney and liver clearance rates decline. When we administer general anesthesia, we deliver a combination of induction agents, muscle relaxants, and volatile anesthetic gases. These drugs bind to receptors across the entire central nervous system. They do not gently quiet the brain. They suppress it systematically, including the regions responsible for memory consolidation, spatial orientation, and sustained attention. And in a patient over 70, the kidneys clear these drugs measurably more slowly than in a younger patient, sometimes significantly more slowly. The drugs linger. The receptor exposure is prolonged beyond what the dosing schedule technically accounts for. The neurological recovery window stretches in ways that are not always predictable in advance. What happens next is where the real risk lives. In roughly 30 to 40% of patients over 70, something appears in the first 1 to 3 days following surgery. Postoperative delirium. I want you to understand what this actually looks like in a real human being. Because the word sounds clinical and distant, and the reality is anything but. The patient wakes from surgery and does not know where they are. They believe they are at home or in a place from 30 years ago. They become agitated, or they go completely still and unreachable. Sometimes they see things that are not present in the room. Sometimes they do not recognize the family members who are standing right beside them, holding their hand. I had a patient's son describe it to me this way. After his mother's elective knee procedure, she looked at me like she was trying to remember who I was. She kept asking where her sister was. Her sister passed away 15 years ago. We were standing there, 4 of us, and it was like she was in a different room in a different decade. The family had been waiting in the corridor, expecting their mother to be groggy, but essentially herself. What they found instead changed the texture of that entire week. And here is the part that I need you to understand, because this is the domino effect that most patients are never warned about before they sign the consent form. Delirium is not always temporary. In a significant proportion of elderly patients, delirium is followed by something called post-operative cognitive dysfunction, clinically abbreviated as POCD. The memory does not fully come back. Processing speed stays sluggish. The sharpness that existed before surgery, the ability to track several things simultaneously, to recall names without effort, to follow a conversation without losing the thread, it is diminished. Sometimes for weeks, sometimes for months. In some patients, the evidence suggests the decline does not fully reverse. And consider what this means in practical human terms. This is a person who was driving independently before the operation, managing their own finances, cooking for themselves, living fully and on their own terms. And now a family member is quietly rearranging their own schedule to help. Conversations are happening behind closed doors about the level of support that may now be needed. And the surgery that was meant to improve their quality of life has instead become the marker in time when everything shifted. This is not theoretical. The data has been accumulating since the 1990s. Post-operative cognitive dysfunction in elderly patients is one of the most actively researched areas in anesthesiology right now, precisely because the aging population is growing rapidly. And the clinical stakes are rising year by year. Now, let me be precise, because I want to be accurate and fair about where the science stands. Researchers are still actively debating whether general anesthesia directly causes lasting cognitive decline, or whether it accelerates a neurological process that was already beginning very gradually. The science is ongoing, and honest practitioners acknowledge that uncertainty. But here is what I can tell you from clinical practice. We consistently see better cognitive outcomes in elderly patients who receive regional anesthesia rather than general anesthesia. The difference is not marginal. It is clinically meaningful. It shows up in delirium rates, in length of hospital stay, in how quickly patients return to independent function, and in family reports of cognitive baseline after discharge. That pattern is consistent enough that many leading surgical centers in the United Kingdom, across Scandinavia, in major academic medical centers throughout North America, have made regional techniques their default approach for elderly patients wherever it is medically feasible. Which raises the obvious question: why is this still not standard practice everywhere? Why are so many patients over 70 still receiving general anesthesia when alternatives exist? This is where the gap lives, and it is the central gap I want to close for you today. Many patients do their research. They become genuinely concerned. They arrive at the preoperative consultation and say something like, "I have read about cognitive risk with anesthesia. Is there another option for my surgery?" And sometimes, not always, but often enough to be a real pattern, they hear this: "This is standard procedure for this operation," or "Don't worry, you will be completely safe," or simply, "We do this with everyone." And the patient backs down, because who are they to push back against the surgeon? But here is the problem with standard procedure. Standard protocol was designed for the average patient population. The average patient population, weighted across all ages, skews significantly younger. When you are over 70, you are not in the average patient population for anesthetic risk. You are in a different physiological category, with different drug metabolism rates, different cerebrovascular reserve, different receptor sensitivity, and different cognitive vulnerability. Your anesthetic plan should reflect that individual reality. I am not saying general anesthesia is always avoidable. There are procedures where it is genuinely necessary. Complex cardiac surgery, certain neurosurgical operations, long abdominal procedures with specific airway or positioning requirements, emergency situations where time does not permit a careful regional setup. When general anesthesia is truly necessary, a skilled anesthesiologist will do everything possible to protect the aging brain. Careful drug selection, minimized total doses, brain activity monitoring where appropriate, and managed sedation throughout recovery. But the reality is that general anesthesia is far more avoidable than most elderly patients are ever told, because there are 4 specific regional techniques, each precisely matched to a different type of surgery, that allow a patient to undergo a major procedure without deep brain suppression. I am going to give you all 4 right now, with the detail you need to have a genuinely informed conversation. The first technique, and I want to start here because it is arguably the most transformative development for surgery involving the limbs, is the peripheral nerve block. The name sounds technical, but the concept is elegant in its simplicity. Pain signals from any surgical site travel through specific named nerve pathways before they ever reach the brain, the shoulder, the knee, the hip, the hand, the foot. Each region is served by identifiable, precisely mappable nerve bundles that follow predictable anatomical routes. What if we intercept those signals before they travel? That is exactly what a peripheral nerve block does. Using real-time ultrasound imaging, technology that allows the anesthesiologist to visualize the precise location of the target nerve on a screen in real time, a small amount of local anesthetic is placed directly adjacent to that nerve bundle. The result is complete numbness of the entire surgical region, not the whole body, not the entire spinal cord, precisely and only the operative site. The patient is awake throughout, or resting in very light, comfortable sedation, a gentle drowsiness that is nothing like unconsciousness. The brain is not suppressed. There is no tube in the throat, no ventilator, no systemic pharmacological shutdown. The patient breathes on their own, maintains their own airway, and can respond and speak if needed. And the block continues working for 12 to 24 hours after surgery ends, that critical first day of recovery, typically the most painful, is already covered by the local anesthetic placed before the first incision. The patient requires dramatically less opioid pain medication afterward, and opioids in elderly patients carry their own significant cognitive risks: confusion, excessive sedation, balance problems, falls. Avoiding large doses of them is a meaningful benefit on multiple levels. For hip replacements, knee replacements, shoulder repairs, and hand surgeries, peripheral nerve block is genuinely changing how anesthesia is approached in elderly patients. The outcomes data is substantial and continues to grow stronger each year. The second technique is epidural anesthesia, and this is the appropriate approach for larger operations involving the abdomen or the chest. You may have heard of epidurals in the context of childbirth. Epidural anesthesia for major surgery in elderly patients is equally powerful. And for procedures like bowel resection, aortic surgery, or certain thoracic operations, it can be the single most significant cognitive protective factor available to the patient: a thin, flexible catheter, roughly the diameter of a strand of thick thread, is placed in the epidural space. That is the space just outside the membrane surrounding the spinal cord, in the middle of the back. Through this catheter, local anesthetic is delivered continuously throughout the entire operation, covering the full surgical area with precision and consistency. The result is that the patient requires dramatically less general anesthetic agent. In many cases, the epidural provides sufficient pain coverage that the general anesthetic component is reduced to a minimum, just enough to ensure comfort and stillness, rather than the full pharmacological load that would otherwise be required. The brain is largely spared the deeper chemical suppression. The catheter remains in place for 2 or 3 days after surgery. Post-operative pain is managed continuously with precision, using a fraction of the systemic drug doses that would otherwise be needed. The patient moves earlier. Respiratory complications associated with inadequate pain control are reduced. The entire recovery trajectory shifts in a direction that is measurably better. The third technique is spinal anesthesia, distinct from epidural, and the preferred method for surgery of the lower body: hip fractures, knee procedures, bladder and prostate operations, lower abdominal hernia repairs. A single carefully placed injection delivers local anesthetic into the cerebrospinal fluid in the lower lumbar spine. The anesthetic spreads upward to a precisely controlled level, creating complete numbness from roughly the waist down. The effect typically lasts 2 to 4 hours, covering most lower body procedures comfortably. The patient can doze lightly during the operation, listen to music, or simply rest quietly. Some request mild sedation for comfort, but the brain is not chemically suppressed to the level of general anesthesia. The airway is maintained entirely by the patient themselves. No tube, no ventilator, no forced pharmacological shutdown of consciousness. For elderly patients with hip fractures in particular, spinal anesthesia has become the preferred standard in many leading centers worldwide. The data on delirium reduction compared to general anesthesia is consistent across different patient populations, different countries, and different healthcare systems. This is not a niche or experimental approach. It is mainstream medicine moving in a clear, well-supported direction. The fourth technique, and this one surprises many patients because they had never considered it as an option, is conscious sedation combined with local anesthesia. This is the approach for smaller procedures: cataract surgery, carpal tunnel release, hand and wrist operations, minor hernia repairs, certain skin procedures, and biopsies. The patient receives carefully titrated sedation, producing what we call a twilight state: relaxed, calm. Anxiety absent. If someone says your name, you respond. You are aware at a gentle level. You are not unconscious, not intubated, and your brain is not carrying the full pharmacological burden of general anesthesia. The local anesthetic is injected directly into the surgical site, providing complete pain control for the procedure itself. For cataract surgery specifically, a procedure that takes less than 20 minutes in experienced hands, many elderly patients are still receiving general anesthesia purely out of institutional habit and departmental routine. Conscious sedation is perfectly adequate, gentler on the aging brain, associated with faster recovery, and allows the patient to go home the same day, often feeling nearly normal within hours. The difference in the cognitive experience for the patient is significant. Now let me give you the precise language to use at your pre-operative consultation, because knowing the 4 techniques is only half of the work. The other half is knowing how to open the conversation without being dismissed or reassured away from pursuing it. When you sit down with your surgical team before the operation, say this: I have read about the cognitive risks of general anesthesia for patients over 70. Can we discuss whether a regional approach is appropriate for my specific procedure to reduce the risk of post-operative delirium and cognitive dysfunction? That question does 2 things simultaneously. It signals that you are informed and specific, not vague, not anxious, but knowledgeable about the clinical literature. And it opens a genuine clinical conversation rather than prompting a reflexive reassurance. If the answer is that general anesthesia is truly necessary, ask why. What specific aspect of this surgery requires general anesthesia that a regional technique cannot address? That is a fair, specific clinical question. It deserves a fair, specific clinical answer. If what you receive instead is, this is just what we do routinely, without further clinical reasoning, that is the moment to request a separate consultation with the anesthesiologist directly. The anesthetic plan is substantially within the anesthesiologist's decision-making authority. A good anesthesiologist who works regularly with elderly patients will often welcome exactly this conversation. They think carefully about these risks. They want to protect you. They may simply need to know that you want to have the discussion. Because many patients never raise it, and teams default to what they always do. I want to leave you with 2 patients, both real patterns I have witnessed in different forms across many years of practice. The first is a 76-year-old man, sharp, fully independent, drives himself to appointments without difficulty, manages his own finances, reads widely, calls his grandchildren every Sunday without being reminded. He undergoes a hip replacement under standard general anesthesia. The surgical result is technically excellent. The hip functions well by the 6-week mark. 3 weeks after surgery, his daughter calls the office. He got turned around on a drive he has made hundreds of times. He forgot a detailed family conversation that happened the day before. A conversation about something that mattered deeply to him. He seems slower to find words that used to come easily. The hip healed, but something else did not fully come back. And no one had told them before the operation that this was a known risk. The second is an 82-year-old woman with a hip fracture after a fall. We performed the repair under spinal anesthesia with light sedation. During the procedure, she spoke with her daughter across the surgical drape, asked about the grandchildren, made a small joke about the paper cup they made her wear. The procedure took under 90 minutes. By day 2, she was working with the physiotherapist, By day 4, she was home. 1 week later, she called the office. She wanted us to know she was back in her garden. Her mind was completely clear. I have watched both of these stories play out in different forms more times than I can count. And the difference between them often comes down to a single conversation, one that either happened or did not happen before the operation began. The surgery protects the body. The right anesthesia protects the mind. And at 70, at 75, at 80, your mind is worth every bit of that conversation. Before any surgery, for yourself or for someone you love, write these 4 options down and bring that piece of paper to the consultation. Peripheral nerve block for operations on the limbs and joints. Epidural anesthesia for major chest or abdominal surgery. Spinal anesthesia for procedures below the waist. Conscious sedation with local anesthesia for smaller operations. And write the question down too. Can we discuss whether a regional approach is appropriate for my procedure to reduce the risk of post-operative cognitive complications? Ask it before you are in the operating room, not after you are recovering in it. Informed patients receive better, more individualized care, not because the system is adversarial, but because a patient who asks specific, knowledgeable questions prompts a specific, considered response. It genuinely changes the dynamic in the room. It invites your team to think carefully about your individual situation, rather than defaulting to the standard protocol designed for the average patient across all ages. Every patient is different. Every procedure is different. If you have existing cardiac conditions, if you are on anticoagulants, if there are anatomical considerations, all of that factors into the decision, and your physicians know your individual situation in ways I cannot from here. What I am giving you today is the framework for a better, more informed conversation, the starting point, not the final word. If this was useful, share it with someone who has surgery coming up, or with a family member who cares for an elderly parent. It takes 30 seconds to send, and it might genuinely change the conversation they have with their doctor. And if you want to understand what happens to the aging brain across the full course of hospitalization, not just during the surgery itself, but throughout the recovery process, and why those first 72 hours after the procedure are so critical for long-term cognitive outcomes, I covered that in detail in another video. The link is in the description below. Take care of yourself and take care of your mind.